Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased again today to be talking with Dr. Daniel Hofer, a family physician who is Chief Medical Officer, Outpatient Palliative Medicine. He's a Medical Director for Sharp Hospice Care. He's a family physician at Sharp Stealing Medical Group in San Diego, California. Dr. Hofer, I'll be turning things over to you.
Thank you again, Larry. This is presentation number 5 in the 6 series course. It's about evidence-based medical prognostication. And I would tell you, you can prognosticate about a lot of things, and I'm going to show you how we used prognostication and as a model for that prognostication regarding our community-based palliative medicine program. But the principles can be applied anywhere. You can use this in the emergency room, you could use this in surgery, you could use this in family medicine, but it needs to be used. That's my only comment, and then let's get going and we'll go from there. Multiple disclosures as before. None of these will affect what we're talking about today. So how did this community-based palliative program, when there are dozens of palliative programs across the country, receive so many awards? Circle of Life Award, we're now the model for palliative medicine in California, SB 1004. Soon to hopefully become a national model, the National Association of ACO's Innovators Award. We received the Certificate of Distinction and the Jefferson Hearst Population Award. And I can tell you that one of the most important pillars of our community-based program is the ability to learn how to prognosticate and provide anticipatory guidance. In fact, if you looked at our palliative program, you would have to decide where it fits in the bigger scheme of palliative care with primary care, which is chronic disease management. I started in hospice and realized that the benefits of hospice need to be moved upstream. So we created the premier community-based palliative program in the country. And you would say, well, there's other programs that were there before you, but I'm going to show you what we did to make our program so much more unique. And then we expanded at Sharp to inpatient palliative medicine. That was actually the opposite of what most palliative programs were in the country. 90% of programs in the country were in the hospital first, and then they went to outpatient. We did it the other way around. The discussions we've been having up to this point about the anticipatory guidance in earlier stages and using palliative skill techniques for the geriatric population, I call that geropalliative medicine, to provide anticipatory guidance and better decision-making for this demographic. So what made our community-based palliative program so unique? And the answer is that we did not wait for our patients to be hospitalized, and we did not piggyback off of home health. And therefore, our patients never had a Medicare Part A skilled need, and they never were hospitalized for the majority of patients admitted to the program. In fact, I can tell you as a family physician, I have now been taking care of patients with heart failure, dementia, COPD, cancer, renal failure that never see the inside of the hospital. And what did we do? We moved all of that aggressive care upstream to prevent the unnecessary utilization of the hospital as a default tool for the management of our patients when we can anticipate what's coming for these patients. I would point out as well that these patients don't need to be homebound. A lot of people have programs that are based on homebound patients. These patients simply have to be at risk of starting to use the hospital as a tool to manage decompensations. So who belongs to this program? Well, there's lots of people in the program: physicians, volunteers, chaplains, pharmacists, nurse practitioners, nurses. We are all involved in managing these patients upstream. We provide them emergency kits. We call them T kits to separate them from E kits, which we use on hospice. But these are ways to manage early decompensations to prevent the patient from extending to the point where they do have to go to the emergency room or the hospital. And it's highly based on a team approach. So our providers in palliative medicine do not take over the care of the patient. We are consultants to you, the primary care physician and the specialist, and we work as a team to manage these patients as they're progressing in the inevitable consequences of the natural progression of their illness. Prognostication is huge in the management of these patients. And I would remind providers that prognostication was considered the most valuable tool a physician could have in Hippocratic physicians at the beginning of healthcare. And I'm going to read this quote to you from Hippocratic physicians because it's such a powerful tool. And ask yourself today, does it have the same meaning? And here's the quotation. It is the most excellent thing for the physician to cultivate prognosis, for by foreseeing and foretelling the present, the past, and the future, and explaining the omissions for which patients, and I would include providers, have been guilty of, he and she will be more readily believed to be acquainted with the circumstances of the sick, so that men and women will have the confidence to entrust themselves to such a physician. As a physician, you need to not only know how to diagnose and treat a problem, you need to understand the inevitable consequences of the natural progression of that illness so that you can forewarn the patient and their family about what's coming so they can make decisions upstream in anticipatory guidance so they can have the best care under the circumstances of their health. This is a old quotation out of the Lancet from 1985, but I think in many ways it's still applicable today. Not sure if it's as applicable as in the past, but here's the quotation. Why has there been so little research in individual prognosis in the terminal period? One explanation is that doctors unconsciously need the uncertainty to justify to themselves their actions for an individual patient. Now, I grew up in the 80s in healthcare, and that was a highly paternalistic decision-making process. And we justified much of what we did consciously or unconsciously by remaining uncertain about what the best thing to do was, and we default to intervening. Well, that default process does not need to exist. And I don't know if that's the case now for most providers, but I do believe that most providers don't have any professional training in how to prognosticate, so that leaves them here anyways. There are cases where I've been told that doctors unconsciously want the uncertainty, such as ER doctors that have told me they don't want to be certain with pulsed and advanced directives because it makes it harder for them to do their job. Perhaps some surgeons or even primary care physicians that want the uncertainty because then they can move forward in what they're used to doing instead of having to work a little harder to define the pathway that's best for the patient. I don't think that's most patients, but many physicians have been honest to me about their feelings, and that's what they're telling me. What's part of the problem? This was a great article published by Nicholas Christakis. It looked at the number of pages in medical textbooks over the last century or so, and it looked at what they were dedicated to. The second bar from the right, the dark diagonals going down, and that's the pages dedicated to prognostication. If you look at 1982, physicians were fairly well balanced. We taught prognostication as much as anything else. You move to 1947, it's starting to disappear, and by 1988, there are 0 pages dedicated to the professional skill of evidence-based medical prognostication. The same problem occurred with pathology. What do we do now? This was certainly the way I was trained. What's the diagnosis and treatment? And anything you know about prognostication is just little tidbits here and there instead of learning formal prognostic skills. So what we're going to embark on today, you're not going to become a professional prognosticator with one presentation, but you'll get the idea of the benefit of relearning these professional skills is moving away from just thinking diagnosis and treatment, but diagnosis, treatment, and prognostication, and making that a part of every visit with every patient. So why do we prognosticate? Because we absolutely want to be sure that the treatment path is consistent with the goals of care of the patient, not as a part of the throwaway population where we used to throw away the patient's priorities and replace them with our own, but to make sure that the care we're providing is consistent with the patient's goals. We're going to move away from the outdated model of reactive care and move towards proactive care, because if you know what's coming, you can do a better job preventing those negative outcomes. And it's always interesting to me because the most appropriate care and the most effective care is far more cost effective, and prognostication helps us achieve those goals. So here's a research article, very popular article in palliative medicine. This was published in the British Medical Journal. It looked at 343 doctors. This was primary care physicians and specialists. They were asked to prognosticate on 468 of their terminally ill patients, and what did they find? They found that only 20% of the time were physicians accurate in their ability to prognosticate that the patient was terminal. 80% of the time they were inaccurate, but what's particularly concerning is 63% of those 343 doctors were markedly overly optimistic. They were off by 530%. And I can tell you as a hospice provider, we get these patients onto hospice all the time. The patient will come to us and say, well, my doctor said I had 6 months to live, but because those providers lack prognostic skills, they didn't realize that patient was weeks from their death. And that, in my opinion, is one of the main drivers as why the median length of stay on hospice in this country runs about 19 to 22 days. So 3 weeks instead of 6 months. And that's an unfortunate problem for families because they're very frustrated and angry or distraught over the fact that the reality is that their loved one had much shorter time to live than they were being told by their primary or specialty providers. When we looked at who was better at prognosticating, it didn't matter if it was man or woman, it didn't matter board certification, didn't matter how optimistic the physician was about their professional skills, it didn't matter if they'd been used to referring to hospice, it didn't matter if they had similar patients in the last year, it didn't matter if they were a specialist or not. In fact, specialists in general tended to do worse than primary care physicians, and that's except for oncologists that were kind of all over the place. It just depended with oncologists. You can put that group aside. They were a different subgroup. There was a negative correlation with accurate prognostication the longer there was that the patient and the doctor had a relationship. And I don't actually think that's bad. That just testifies to the humanity of providers, that we care about our patients. But it is our professional skill to be able to step out of our shoes and to be able to see what's actually going on so we give accurate information to the patient and to their family. And of course, there was a negative correlation if it had been a long time since you'd seen the patient. The good news is the longer you've practiced, probably just by experience, became more accurate in your ability to prognosticate. So the upper quartile of physicians gave better prognostic information. The tragedy, of course, is only made worse by the fact that families are markedly more overly optimistic than healthcare providers. And I have to tell you this because I used to work as an expert witness defending physicians. And so I've done this as an expert witness or a hospice provider. But when it came to defending physicians, I could always prove the patient was going to die. But the patient's and family's perspective was way off to the left as to where the patient was in reality that was way off to the right. And sometimes the physician's perspective was there too. So what our job should be, not just in palliative medicine and avoiding me as an expert witness, but is to align reality with where the patient actually exists. And that takes some professional skills, and that's part of the training you're going to get today. But there's one other barrier to doing this right, and that's how do we represent ourselves. And this happens to be a research article looking at oncologists with terminal cancer patients. There's other specialties that have the same problem. But what I'm going to show you is that when the oncologist was asked by the researcher, what type of a response do you give to your patient? So this is oncologist to researcher. This is not actually the oncologist in front of the patient and family. They would tell the researcher, 37% of the time, I just tell them what I think. 40% of the time, they deliberately overly underestimated or overestimated their prognostic efforts. And 23% of the time they declined to respond, which I found particularly disturbing or concerning. Why did they not respond at all? It's just a researcher asking a question. So think of yourself as a patient or a family. You want to know about the prognosis for yourself or your loved one. Physicians are markedly overly optimistic. Patients are markedly overly optimistic, as are families. And the probability that you're going to get an accurate estimate for your own personal needs is extremely low. And that's a serious problem in healthcare that we need to remedy. So what we need to know when we're prognosticating is that there's more than one type of prognostication. Most of us, when we're talking about prognosis, think about time. Time is how long until the event will occur. So in this case, we've been talking about mortality, but you can have other time events that are of importance to the patient or family. Event prognostication is what is the next event in the expected series of events. And that's actually quite easy to do. Probability is how likely is that event to occur. And in fact, we have significant research about probability. So when it comes to training, how good are doctors at the different types of prognosis? Time, we're very poor, which is the one we tend to perseverate about. We should be thinking about the other areas as well. Event prognostication, we're extremely good at. We need to be using that when we're talking to our patients and their families. And probability, we're also very good at. We just have to make the efforts to look up the statistics to be able to share them with our patients and families. So one of the reasons, or the reasons that doctors are poor prognosticators is because we lack the training, and we perseverate in particular about time prognostication. Expand your prognostic conscience to event and probability, and then use those to guide you when it comes to time prognostication. So let's use what we've talked about so far in thinking about how we develop the transitions program. The transitions program is patients with advanced illness who are not early in their disease process, but they're in what we call the pre-terminal stage, the last 6 months to 3 years. They're not hospice appropriate yet, but they may become so soon. And what you need to ask is, what is the main diagnosis when you're looking at the patient? Some patients have multiple diagnoses, but one is leading the race to take the patient to the end of their life, whether it's heart failure or heart failure with frailty, but many of these patients might have diabetes or COPD. You simply have to ask, what's the leading diagnosis for which we are going to prognosticate? And then you have to ask, is it truly late stage? There is a difference between an old person getting older and an old person who's approaching terminality. So you need to be sure that the patient is farther along in the process to be able to say the patient's in the pre-terminal or the terminal period. You should also be asking, has the patient had maximum medical therapy? Because if the patient has congestive heart failure and their ejection fraction is 27%, but they're going to go for a coronary artery bypass, that ejection fraction may improve significantly, even back to normal. So we have to wait until they've had maximum medical therapy. Medicare's criteria for maximum medical therapy is, number one, there's truly no other pathway to improve care in a traditional pathway. So no more interventions or no more procedures. Number two is the patient's intolerant to further therapy. So they've had all the surgical interventions, but you can't give them any more diuretics when their blood pressure is 90/50 and they still have curly B lines and they're short of breath and fluid in their lower extremities. You know, those patients have had further therapy. More therapy is more likely or as likely to kill them as the disease itself. And the patient refuses further treatment or chooses a different pathway, and that's probably the most common cause of maximum medical therapy. And then once in a while, patients are so non-compliant, they're repeatedly hospitalized. Medicare would accept that as a definition of maximum medical therapy. What's interesting on our transitions program, we're so good at keeping people out of the hospital, we substitute, has the patient been hospitalized with, has the patient used their T-kit? Because if the patient repeatedly uses their T-kit, they may have maximum medical therapy qualifying them for hospice at that point. So when you prognosticate, it's important to look at as many tools as you can. More is more. The first set of tools you need to look at is general prognostic information. Is the patient older? Is the patient male or female? Males tend to have worse outcomes in prognostic modeling. What's the patient's BMI? That's a J-shaped curve. Particularly low BMIs are bad. When they get higher, they're bad as well, but it's the really low ones that have a poor prognosis. Any form of weight loss, unintentional weight loss in particular, is concerning. And depression or other psychiatric concerns, and frailty is a particularly important syndrome, but any geriatric syndrome. I tell you something about psychiatric illness. A lot of people don't know this, but people with severe psychiatric illness have about a 10 to 25 year decrease in longevity. And just putting that in your back pocket as a prognostic tool when you're deciding where the patient is in their biologic age is something important about patients with psychiatric illness. So there's biometric models, and there's functional decline patterns, there's specific biologic data and general biologic data, as well as adjusting for your personal tendencies. That's how you become an accurate, effective, and professional and compassionate information sharer to your patients when you prognosticate. So you get that general information, you look at their biometric model, you look at their functional decline pattern, you look at disease-specific and non-specific biometric markers, you adjust for your personal tendencies, and then you can give an accurate prognosis to your patient and their families. These are examples after you've collected general information of biometric models. The New York Heart Association BOLD model for pulmonary disease, MELD for liver, CPT for liver, SEER, ECOG, FAST for dementia. What comes after a FAST-6A? It's a FAST-6B. It's expected. And you can tell a patient that a FAST-6D is followed by FAST-6E. FAST-6D means they're incontinent of urine. FAST-6E means they're incontinent of stool, and that's something most families would want to know is coming next when they're managing their patients. There's other biometric models. They're not all as good at time prognostication as these other models can be, but they may be more for event prognostication, such as Medicare's LCD. Now, Medicare's LCD criteria are notoriously poor in prognosticating 6 months or less. So you have to look at them as a guide. And in fact, I would refer to the ADEPT study, which showed that 95% of dementia patients, even though they died, never met Medicare's LCD criteria. So if you're not able to expand your skills to understand where the patient is, looking at other prognostic information, very few patients will actually qualify for Medicare under hospice criteria. So 4 basic functional decline patterns after you've done the first 2 is sudden death, end organ disease, cancer, and debility. And these are those shown graphically. I think terminal illness such as cancer is probably not the gradual or the rapid, but still gradual, consistent decline you see in the upper right-hand box. It's turning more into the lower left-hand box, or even the lower left-hand box is a little bit outdated because programs such as ours have gotten rid of all those little dips where the patient went into the hospital and came out a little bit worse. We are managing these patients so proactively that it's just a continuous decline over time that we're helping patients and families understand what's going on in that process, and they do not have to participate in the revolving door of hospitalization. So let's take a look at ADL decline, specifically looking at some of these functional declines, and you can get a feel for what I'm talking about. That's cancer on the bottom, and historically cancer showed a significant ADL decline as patients approached the last 6 months of their life. And what does that tell you? When you see ADL decline, you're actually using your eyes to prognosticate. You're seeing the patient get worse. But what do you see with patients with end organ disease, COPD, congestive heart failure, diabetes, having had a stroke? ADL decline is actually fairly slow and minimal. And in fact, if you look 12 months out compared to 6 months out, what do you see? There's almost no change in ADL function. So if you're using your eyes to determine the patient 6 months prior to death, you're going to miss the opportunity to recognize that you have a terminal patient because you were relying on visual cues instead of all of the other cues that are available to tell you where the patient exists. So here's a pearl about looking at end organ ADL function and what patients look like 6 months prior to death, these patients are as alert and oriented at 6 months as they were at 12 months. They're still ambulatory and they're not in pain. Now, if your image of a terminal patient is somebody who's confused or cognitively suppressed, lying in bed, writhing in pain, that needs to be updated to a professional evaluation where you can look at the patient and say, well, using my professional prognostic skills, I can tell you that this is where you're at in the life process. If you have some issues you want to take care of, now's the time to do it. And we really need to know what your goals of care are. If you have an event, somebody might call 911 and you'll end up in the ICU. Which of course is fine if that's what they want, but we know most of our patients don't want that. So you can use ADL decline in many ways, not just for terminal prognosis. These are studies looking at risk of hospitalization. These studies have been validated. This was a study with 6,070 patients followed for multiple follow-ups over several years, and they looked at ADL decline. Severe disability was defined as 3 or more ADL deficiencies. Catastrophic severe disability was going from 0 to 3 ADL deficiencies between intervals of being evaluated. Gradual severe disability was having had 1 or 2 ADL deficiencies and then 3 or more. And in the year for which severe disability developed, if the patient had catastrophic severe disability, there was a 72% chance that patient would be hospitalized. And what type of prognostication is this? That's event prognostication. I see you in my office, you suddenly have 3 severe ADL deficiencies. That's a catastrophic severe disability. Your chance of being hospitalized that year is 72%. As a family physician or primary care physician, would you do anything about it? And what does your program and your system have to do for these patients because they may not have a Medicare Part A skilled need or they may not already be hospitalized? And for gradual severe disability, it's about 50%, 48.5%. If the patients had 1 or 2 ADL deficiencies, just the standards, about 22% of those patients were hospitalized and no ADL deficiencies. The control is 14%. So if patients develop catastrophic severe disability compared to just patients with no disability, no ADL deficiencies, they were 5 times higher, more likely to be hospitalized. You can add your skills that you've developed so far to prognostic markers, disease specific and non-specific. And of course, with all things, we look at the absolute level and we look at the progression of markers. So for example, cholesterols, total cholesterols under 150 are associated with higher mortality rates. And the lower they get, the worse it is, especially if those progression of markers have dropped precipitously. That is a warning sign. It's something not a lot of people do. And it's hard to convince them to use cholesterol as a marker, especially because everybody's on statins these days. So when you look at time prognostication, one of the things you should never say is that I would be surprised if you were here in 6 months. We still hear that told to patients once in a while. But the professional way to translate information is to say, well, if I had 100 people in your situation, this is what medical information says the bell curve looks like. And then you can decide whether they're on the left side or the right side of that bell curve and guide them in their decision making. Another way you might be able to say this is say best case scenario and worst case scenario. Best case scenario, you're here in a few years. Worst case scenarios, you're not here in a few months. Event prognostication is the prognostication which guides the patient in the expected series of events. And we have all participated in this, whether we've done this as a physician or not. On some level, every single person listening to this now has participated in event prognostication. And where is this? We've all done it. And the answer is it's an anticipatory guidance in children. In fact, it's so standard in pediatrics. If you didn't do this, you wouldn't be able to practice pediatrics. Now, most people think of anticipatory guidance as the developmental events that occur as the patient ages. So we can look at those and say your baby's developing normally, or if not, we can intervene to do something about it. But anticipatory guidance has another level. It's to prevent adverse events. So when the patient starts to crawl, we don't want that patient to choke or poison themselves. And I worked at Children's Hospital in LA. We were constantly removing pieces of pet food or little things that had dropped on the ground, got into the bronchioles of these children that started to crawl. And we were hoping not to ever have to do that, but it was something, unfortunately, that occurred routinely. Another part of the anticipatory guidance is to keep newborns from drowning. And so in my residency, I did hundreds of deliveries. And we would tell the parents that 1 day, 1 week, 1 month, 2 months, 4 months, that you do not leave your child in more than 2 inches of tepid water. You never leave them. I don't care if something's burning on the stove, somebody is knocking on your door, or if the phone's ringing in the other room. They didn't have cell phones back then. You make the child safe, and then you can go do whatever you need to do. Because what's the number of acceptable drownings you're looking for when you retire as a family physician or pediatrician that takes care of newborns? What's the goal? Well, obviously the goal is 0. We can anticipate what is coming, and so it doesn't matter that it may not happen to all of them. It happens to enough of them that the goal we're shooting for, because we have anticipatory guidance, is 0. Well, guess what? On the other side of the bell curve of life, we can also anticipate that everybody with heart failure is going to drown in their own fluids. But it's interesting, and I'll ask you, what's the number of acceptable drownings for your patients with heart failure in this country? It sure isn't 0. It seems to be now that you can only drown once every 31 days because that would be considered poor care if they were readmitted. But the reality is they never should have drowned once until their final demise, because we can anticipate and proactively and aggressively manage these patients upstream so that we stop using the hospital as a tool to manage decompensations for the advanced elderly population, putting them through horrible suffering, so that we can practice our professional skills at repairing patients instead of health care keeping patients from getting sick in the first place. And you could say the same for COPD, dementia, cirrhosis, renal disease. All of these diseases have courses where you can use event prognostication to prognosticate the inevitable consequences of the natural progression of their illness. One of the tools you can use is the Karnofsky Performance Status Scale. You can see how that disease is affecting their functional decline, and can use that as a tool. We use this very frequently in palliative and hospice medicine. So that's enough talk about what to do. I'm going to give you an actual example. This was a heart failure patient of mine, 82 years old, about 15 years ago, came to see me. He had had a quadruple bypass and 2 stents placed. He was now my patient. He'd been co-managed with the cardiologist, and he came into my office with shortness of breath, and we were easily able to make the diagnosis of congestive heart failure. We put him on the proper medicines, but we started also to look at his prognosis. And what would you say? General information. He's older and male. That puts him at some risk. He was not depressed, I can tell you that. He did not have any geriatric syndromes. He had not lost weight. His BMI was 26. So I expected him to do fairly good. When I look at a prognostic model, the New York Heart Association, most patients are in stage 3 for 5 years. So you can anticipate, if you manage him well, he's got about 5 years to go before any negative consequences, or he enters stage 4, which has a mortality rate of 30 to 50% at 1 year. The problem, of course, for these patients is every single time they come in, November 6th, May 7th, June 8th, they're a little bit more short of breath, and you're constantly adjusting their medications over time. So you're giving them more medications, but they feel and look the same, so they think they're exactly the same way they were when they first started. In fact, they're actually getting worse. And what do we know? The more medicines you have to use to manage a patient with heart failure, the worse their prognosis. So we looked at functional decline, or general information. We looked at medications as a tool to prognosticate. You can also look at patient's function. This patient came in, had no ADL deficiencies, eventually developed some transfer deficiency, and then a little bit of ambulatory deficiency. And in December in 2010, he came in and had urinary incontinence, which would actually be a third ADL deficiency. When we looked at that, in addition to his pro-BNP, despite the fact that he was on maximal medical therapy, a disease-specific biomarker, we could see that his heart was straining despite the fact that his blood pressure was under excellent control. It was about 100/60, but his heart was straining and he couldn't compensate. If you looked at non-specific markers, you can see that his BUN and creatinine were going up. And I can tell you that work done by Thomas Hayward out of Scripps showed when that number gets to about 55 in the BUN area and a creatinine of about 2.5, the mortality rate is about 50% at 6 months. But going back up here, he's not there yet on his disease-specific or non-specific biomarkers. He is on maximum medical therapy. He's developed a third ADL deficiency. Just looking at ADL deficiency, what do we know? He had gradual severe ADL deficiency, and he has a 50-50 chance of being admitted to the hospital that year. That's the transitions point. That's the point for which we admit the patient to a program before they develop a Medicare Part A skilled need and before they are hospitalized, so that they never have to go through the event of that suffocation, drowning, psychosis, or anything that would cause their life experience to be worse. And so we call that transitions point because that's the point where we put them on this new program that keeps them aggressively out of the hospital. If you want to look at an even more non-specific marker, you can watch the patient's hemoglobin drop. Just more information to tell you you're making the right diagnosis. And we know that as patients age in their disease process, they have more pro-inflammatory cytokines, and that suppresses the production of hemoglobin in many of the biomarkers that we see, including albumin and total cholesterol. And you've seen this before when I've given a presentation, but I'm just going to remind you, we use the exact same tools here to prognosticate how to know a patient was hospice appropriate before they specifically qualified for hospice using dementia criteria from Medicare's LCDs. But if you didn't document that the patient had social withdrawal as a prognostic tool, you didn't document their weight decline, you didn't document their ADL decline, you didn't document the biomarker decline, you wouldn't know, and you wouldn't be able to be paid for or be qualified to put that patient on hospice. And you would end up being a physician who admitted the patient to hospice in the last 2 to 3 weeks instead of giving patient and family services that they had wished for much further upstream. So let me tell you about the program we developed using our professional prognostic skills and how successful we've been over the last 16 years managing these patients. And again, I can't overemphasize that there are now many patients in my group with many providers who never see the inside of the hospital because all of that aggressive care is provided upstream in the patient's home. And these are 2 research articles if you want to actually go read the work that we did. So the cost savings to these patients, hospital costs, because this is what drives medical groups and organizations to move forward with programs like this, was profound. This is the hospital cost per month for the different diagnoses. These are per member per month costs, and for cancer, they're on for about 5 months, and for these other diagnoses, they're on for about 7.2 months. So if you multiply that delta that you see, so with COPD, it's about a $4,200 difference times 7.2. That's about $30,000 in cost savings per patient. So 100 patients, that's $3 million. If you can't develop a program with 100 COPD patients, keep them out of the hospital with $3 million, that would be tragic. I think it can be done anywhere in the country if we have enough support to make this happen. A lot of people said, well, Dr. Hofer, you're saving money because you're spending more money in the outpatient arena. Turns out that's not the case. We actually spent less money in the outpatient arena. These patients are managed so effectively, they stop using unnecessary medicines, they stop visiting doctors, they're managed in their homes, the compliance, the proper use of medicines, the understanding of their care is markedly better. And it was original research to prove that we could do this with the dementia population. The total healthcare costs, again, you can look at the deltas, huge numbers, 7.2 for COPD, heart failure, and dementia would be the number you should multiply the benefit by, and for cancer by about 5. However, this is the slide that makes me the happiest, because this is the slide I'm most proud of. This proves that patients in the pre-terminal period do not need to expect to be hospitalized in the last year of their life, or frankly, any part of the last terminal period. If you manage these patients proactively, you can keep these folks out of the hospital. And our program decreased cancer admissions to the hospital down from 74 to 35%, meaning 2/3 of cancer patients never see the inside of the hospital. COPD patients, it's decreased from 84 to 40%. Most patients with COPD never see the inside of the hospital. Heart failure patients have a decrease of 56%. But what's interesting is most of those hospitalizations are for falls. Heart failure exacerbations have been decreased, and this has been maintained since 2007 by 90 to 94% of heart failure exacerbations have been eliminated. 90 to 94%. I will repeat that. Imagine your heart failure patients that you take care of now, 90 to 94% of the time, they never have a fluid overload. And in dementia, those patients are admitted to the hospital significantly less. And probably the biggest influence in that is understanding delirium, because delirium is frequently confused as a TIA. In fact, I don't get any calls from my family members saying, I think my mom's having a TIA. They call saying, I think my mom's having another delirium episode. What's the percent dying in the hospital? I put this slide in here, as many slides I could have shown you, but this is the one I wanted to show you because a lot of hospitals are trying to fix the problem of death in the hospital. And it just proves to us in hospital systems, if you want to fix a problem that's in a given silo, you may need to move 1, 2, or 3 silos upstream to fix that problem. The deaths in the hospital that you see are probably people who wanted to die in the hospital. Some of them did not, but most of these patients we were able to manage in their homes until the very end. Here's the total cost savings per person over time. You can see most of that benefit is in the last few months, but we were able to get some benefit going all the way out to about 6 months. Now, there were programs before us, and if you take all of our costs, including the cost of the program, it's similar. I'm not precisely comparing apples to apples because the Brumley and other research only looked at the last couple of months, and they were piggybacking off of home health. We looked much further upstream, and were able to maintain that cost savings per month all the way out for many months. How satisfied are people with the program using the prognostic skills of a community-based medically advanced program? Cancer patients' use of hospice went up significantly. That's very important. You can see the benefit of getting patients on hospice sooner, but the satisfaction with the program, this is a Likert scale of 5 only. If we put 4 in there, the worst score was 94%. Many of those would have been 100%. But you can see for scores of 5, incredibly good results, even for improvement of quality of life, which is 74%. I mean, 74% over what they would have expected felt that we gave them a better quality of life by using a program such as this. So with that, I would say a lot of information about prognostication. This is the beginning of your journey. I showed you how you can use that to create a program, and perhaps you can create some programs in your own organizations. And I hope this is helpful to you, and thank you very much.